Hi, it's Dr. Centeno, and thanks for joining me this morning. I've got my green screen on because I've got some big light behind me, so I don't want it to wash out the camera. Threw up the Boulder flat irons. Those are the iconic mountains, kind of, here in Boulder, Colorado, where I live. So today we've got an interesting topic, same format as usual. I'm going to go ahead and spend some time going through a short lecture, 10, 15 minutes, something like that. And then from there, we'll go to answering questions, any questions you want, questions that are questions that are involving this topic, questions that are involving any topic you want. Really doesn't make a difference to me. So today we're going to talk about how to self-diagnose the cause of headaches coming from your neck. This is a big one because lots and lots of CCI patients have headaches coming from the neck, and lots of patients without CCI have headaches coming from the neck. It's a very common thing, but very few patients I find these days get a specific diagnosis of which structure is causing the problem. And until we know which structure is causing the problem, there's absolutely no way to treat that structure to get rid of the headache. So I find that many patients just kind of wander around. So if I can do something this morning to try to teach patients a little bit so that they can maybe try to say, I wonder if it is my C1, C2 facet joint or my lesser occipital nerve or my superficial cervical plexus that's causing my headache. And then hopefully they'll be able to navigate the medical care system better. So title this morning is how to self-diagnose the cause of headaches originating from the neck. So I want you to like, comment, share, subscribe here, just because that's how we get this content out to more patients. If you've been lucky enough to find this weekly broadcast with Q&A, that's great. But obviously, for every one of you that have found it, there's 100 that haven't. And the only way to make sure that other patients can find it is to do things like comment, share, subscribe. Also, again, as I always mention, we've got two different social media sites, threads that I recommend. There's lots out there. Some are better than others, but there's a lot of misinformation going back and forth on a lot of different social media threads. So these are two I can highly recommend. One is my subreddit, RPICL or PICL subreddit on Reddit. It's Q&A with me. There's literally hundreds of questions on there that I've answered. I answer them 7 days a week. And it's getting bigger and bigger as time goes on. As of this morning, we had 224 members on there. And my guess is by the end of the year, we'll be at least 500 to 700. Again, that's Q&A with me. And then there's a patient-only Q&A on Facebook, cervical instability PICL procedure. That's a Facebook thread that I can highly recommend. The folks that run it are very serious about trying to keep it very focused, trying to keep the answers high quality. So both of those spaces are obviously different. One is Q&A with me on Reddit. The other is Q&A with just between patients, but very knowledgeable patients on this Facebook PICL procedure thread. So two different threads there. So most headache treatment worldwide is systemic. And what I mean by that is that, for example, it's take this medication. The problem is if it works, the physician really has no idea what's causing the headache. And the patient usually needs to take that medication forever. Now, most medications have substantial or significant side effects. So that's concerning, right? You would think that it'd be far better if someone could figure out the cause of the headache and treat that cause. But all too often, again, it's just throw medications at the problem. Headaches that come from the neck are called cervicogenic. So what that means is that they basically generate from the head in Latin. This is a very, very underdiagnosed type of headache. Cervicogenic headaches are very common. I would guess that when it comes to chronic headaches, they literally are about 50% of all chronic headaches out there, but they get diagnosed less than 10% of the time. Why do they get diagnosed so infrequently? It's often because neurologists are asked to see headache patients, and neurologists are not trained how to diagnose cervicogenic headache. It's just not part of the training they get. So oftentimes we see patients with headaches coming from their neck or cervicogenic headaches, and they have no idea that it's coming from their neck. And in fact, many times the patients are the ones who say, yeah, I wonder if this is coming from my neck, because every time I do this, I seem to get a headache, and not the doctor. So most patients don't understand that there are a long list of structures in the neck that can cause headaches: upper cervical facet joints, occipital nerve, superficial cervical plexus. I think cervical is spelled wrong there. I'm going to fix that because that drives me a little crazy. Let me just fix that, guys. There we go. Superficial cervical plexus, suboccipital muscles, rectus capitis posterior minor, through the myodural bridge, increased intracranial hypertension, inflamed upper cervical bursas, lots of things that can cause headaches coming from the neck. So if we can identify one of these structures, then we can target that structure and we can treat that structure and get rid of the headaches. So in other words, a specific diagnosis equals a specific treatment and no more headaches. It's a pretty simple thing, actually. I mean, this has been going on in the world of interventional pain management now for 3 decades. Despite that, probably only about 1 in 5 headache sufferers who has headaches coming from their neck actually gets access to any kind of specific diagnosis and specific treatment. So it's a little sad to see when I go online and see all these patients suffering from severe headaches, and most of them just have no idea that it could be originating from a structure in their neck. So figuring out which structures to target with injections to heal that structure can be done by combining history, which is talking to the patient, right? Where does it hurt? What makes it hurt? Etc. Imaging, which structure looks abnormal, so that can give you some clues. And then a hands-on exam. Can we find specifically where it hurts or other abnormalities on exam that relate to that structure? So to help you self-diagnose the structure today, we'll focus on the history part, right? That's the part that you can do at home. That's the part that you know your own body, you know where it hurts, you know where it doesn't hurt, you know what makes it worse, what makes it better. So that's where we're going to focus. Now, for example, this is a map of where specific neck facet joints refer pain. And as you can see here, we've got the C0, C1 facet joint that refers pain up in here. And then the C1, C2 facet joint there, the C2, 3 facet joint there, C3, 4 in here, C4, 5 in there, the C5, 6 facet joint over here, and then the C6, 7 facet joint here in the upper back. So as you might imagine then, if you've got headache pain coming from a facet, or if you've got pain coming from an upper neck facet, better said, it refers pain into your head. If you've got pain coming from a mid-cervical facet, it's the neck or the upper trap. If you've got pain from a lower cervical facet, it's kind of the upper back. This map has been around for a very long time, since the 1990s, and most interventional spine physicians use it, but family doctors don't use it. The surgeons barely use it. Neurologists don't use it. So realize that if you want to get a specific diagnosis, you're going to have to see someone that focuses on targeting specific structures to treat the pain. So let's focus on 3 specific headaches that tie back to the structures that can be easily treated with precise orthobiologic injections. So we're going to go with 3 specific structures today: upper cervical facets, the occipital nerves, and the superficial cervical plexus. Now, you saw a longer list. There's at least 10 things or a dozen things really on that list. But these are the 3 most common that we see in CCI patients, and the 3 most common that we see in just patients walking in with headaches coming from their neck. So let's start first with upper cervical facets, right? These are all joints in your neck. They're about the size of a finger joint. And there are 2, one on each side, one on the right, one on the left. There are, don't know why my camera just died. Assuming everyone can still hear me, but it looks like my camera went out for some reason there. No idea why there. Hold on a quick second, guys. I'm going to try to fix that camera. Well, I'm assuming you guys are still hearing me. If not, let me know. I am monitoring the comments, but not quite sure why the camera went out, but hopefully you can still hear me. So upper cervical facets are about the size of a finger joint. They allow normal neck motion. They allow normal neck motion. Cervical facets can be injured and then refer pain to specific regions of the neck, head and upper back. The C0 through C3 facet joints can become painful and swollen in CCI patients, and they can cause headaches, dizziness, imbalance, and brain fog. So the upper neck facet joints are a big cause of headache, pain, and lots of other symptoms. So if we look at C0, C1, and C2, 3, what we can see here is that C0, C1, and C2, 3 kind of refer pain to the back of the head. C2, 3 a little bit lower, includes a little bit of the upper neck. C0, C1 more than just the back of the head. But it's going to be hard to differentiate these 2. With regard to, is it the C0, C1 or the C2, 3 facet joint? Now, how you can differentiate this perhaps is that the C2, 3 is more commonly associated with dizziness, imbalance, and brain fog. The C0, C1 is more associated with the type 1C sliding of the skull on the atlas type craniocervical instability. And the C2, 3 is more associated with CCI types 3A and 3B. So that's when you have movement happening at C2, 3. Now, C1, C2 facet headaches are pretty pathognomonic. And what I mean by that is that they're this little spot here. So they tend to go right along the base of the skull and across the base of the skull. So it's pretty easy usually to diagnose a C1, C2 facet headache because of this specific pattern that's very different than the 0-1 pattern and very different than the 2-3 pattern. Again, this 1-2 pattern is right across the base of the skull. And it's also true that the C1, C2 facet headaches are associated with CCI types 2A and 2B. So remember, 2A is the one where there's gapping in the ADI, usually inflection. And the 2B is the one where there's side-to-side instability on a DMX at C1, C2. So as far as treatment is concerned, if it's due to instability, then treat the facet joint and the instability. If there's no instability, then just treat the facet joint. And these are precise fluoride-guided injections of orthobiologics using digital subtraction angiography for 0-1 and 1-2. So you can treat these joints all day long or twice on Sunday. It takes a little skill, obviously, and experience to do the higher ones. But the 2-3 facet joint can be widely treated without that additional level of skill, without digital subtraction angiography. And if it's causing headache pain, it's a home run. You inject that 2-3 joint with something. Corticosteroids can be used, but it hurts the joint, but it's a potent anti-inflammatory. Obviously, PRP would be better to use, but the headache just goes away. So it's always been interesting to me to see patients out there who probably have facet pain headaches, and they've never had it treated. So we're going to go now to occipital nerves. And occipital nerves, these nerves weave through the suboccipital muscles. They innervate the back and side of the head. These headaches usually can be made worse by placing pressure in the suboccipital area, but they can also be made better by doing that. So lots of patients will put pressure in the back of their skull, kind of just beneath the skull in the suboccipital area. And that's going to be putting pressure in this area in here. And if that makes your headache worse, or if it makes your headache better, it could be occipital nerve headaches. This is called occipital neuralgia. And they often have a nervy type presentation. Burning, skin sensitivity, intolerance to pressure on the scalp is what usually causes or how these headaches present. So for example, a occipital neuralgia patient will generally have a hard time putting any pressure on the back of their skull, or they can't lie with a pillow there on the back of their skull because it hurts or it bothers them. And they can also trigger occipital frontal, meaning from the back to the front of the head kind of headaches. So greater versus lesser occipital nerves, there's lots of different maps out there. The research shows that it's a little bit all over the place, but bottom line is the greater occipital nerve tends to go more in the back of the head. The lesser occipital nerve is kind of on the side of the back of the head, side of the head, and in a little bit into the ear. So that's how you differentiate these two. Now, it's pretty easy to palpate these for an experienced provider to figure out if it's greater or lesser occipital nerve, and we do that all the time. Then you've got realized a third occipital nerve that comes up right in the middle here. So you've got a greater occipital nerve that's here, a lesser occipital nerve that's there, and then you've got this third occipital nerve coming right up the middle, or the midline of the skull. Now, again, if due to instability, then treat the occipital nerve and the instability. If there's no instability, then just the occipital nerve. Ultrasound-guided hydrodissection of the nerve with third-generation platelet lysate is how this is treated. So this is actually one of the more common hydrodissections we do. We can see either the inferior oblique or the rectus capitis posterior major here. And we hydrodissect in this plane right where the greater occipital nerve lives. Now, the good news is that the suboccipital nerve is also here as well. And the suboccipital nerve provides innervation to the suboccipital muscles. So you kind of get a twofer. If you hydrodissect this entire plane out here under ultrasound guidance, you're getting not only greater occipital nerve, but you're also picking up the suboccipital nerve that innervates, meaning supplies power to the suboccipital muscles. So you get a twofer with that type of occipital nerve hydrodissection. And then finally, the superficial cervical plexus. So the superficial cervical plexus is innervated by C2 through C4. It lives underneath the sternocleidomastoid and comes out the back of the sternocleidomastoid muscle here. And it becomes the lesser occipital nerve, and then the greater auricular nerve, and then it becomes the transverse cervical nerve, which provides sensation to the front side of the neck, and then finally the suprascapular nerve, which provide sensation over the clavicle. So tightness in the sternocleidomastoids, which is very common in CCI patients, can cause this sort of issue. In addition to that, because the vagus nerve lives in the same place, you can also get autonomic symptoms when you have irritation of the superficial cervical plexus. And then many patients find that massaging the sternocleidomastoid muscle or placing pressure there can again make their symptoms better or worse. So headaches with pain or weird sensations in the outside back of the head, side of the neck, or ear is really what we're talking about here. So this is the distribution of all of those nerves coming out of the back of the sternocleidomastoid. And for a headache, it's kind of side of the head into the ear, and or could also include other parts of the ear or parts of the anterior neck or over the clavicle area. So again, as far as treating this, if it's due to instability, then treat the superficial cervical plexus and the instability. If no instability, then just the superficial cervical plexus. This is ultrasound-guided hydrodissection of the plexus underneath the sternocleidomastoid, which is what I'm doing in this picture here. So in summary, specific diagnosis equals specific treatment, no more headaches. To do this, you've got to find the structure that's causing the headache. Then you have to treat that structure with something that can prompt healing in the structure. And hopefully this helps patients today get some clues about which structures might be causing their headaches going forward. I think I'm just going to go start to answer questions. Let me see if I can figure out the deal with the camera. Looks like it's thinking on the camera there. In the meantime, let me start pulling some questions up here. Jessica James, best supplements for ligament healing. I don't really have any recommendations for supplements for ligament healing. We don't have any data on that. We've got pretty good data on supplements that can help with joints. That's been well studied. But there's really no clinical research that I'm aware of for supplements that can help with ligament healing. Some common sense ones might be things like collagen, but we really don't know that for sure. So I'm not quite sure I can make great recommendations there for ligament healing, other than if you have chronic high systemic inflammation, the supplements that can reduce that systemic inflammation are important. And those supplements include things like curcumin, fish oil, etc. So that's perhaps one strategy there. Jessica, can Chiari get worse over time, like with an injury, or the malformation is what it is until it becomes symptomatic? Yeah, it's usually the malformation is what it is until it becomes symptomatic in most patients. Now, obviously, there's a different category of Chiari that we're often not talking about here. And those are usually kids with Chiari that have Chiari 2 and 3, where the back of the brain is well very deep into the upper cervical spinal canal. But that's usually not the kind of Chiari we're talking about here. We're talking about zeros and ones, usually in CCI patients. Cheryl, when I look up, I have extreme pain at the back of my skull between the ears. Yeah, so that could be a 0-1 facet joint. That's something to think about, a 0-1 facet joint. Asthma, maybe. Asthma, Al. Hi, doctor. Can we have the occiput stuck in extension? Would this be caused by the ligaments or the muscles? What is normal distance between the occiput and posterior arch of C1? There is no normal distance between the occiput and the posterior arch of C1. That's never been studied, of which I'm aware. That's, in fact, one of the things that Dr. Katz and I have talked about a few times as to whether or not we wanted to try to study it, because as far as I know, no one's ever published on it before. As far as the occiput stuck in extension, that would usually be due to a type 1 1B or 1C, CCI, where there's some instability in the front of the C0C1 joint. There are ligaments there that can get injured, or there are some issues with there not being enough downward force bringing the occiput into the atlas, and or the occiput is very, very shallow. So those are all different things that could cause something like that. Stephen, if I only have craniocervical syndrome, can I expect some results of posterior PRP? Yeah, I mean, usually for craniocervical syndrome patients, posterior PRP helps, but again, we need to define that, right? Very important to realize that posterior PRP at clinics outside of Centeno-Schultz is probably going to be very different than posterior PRP at Centeno-Schultz. So for example, if you have a craniocervical syndrome, that's usually injecting the C0, C1, the C1, C2, the C2-3 facet joint. And in injecting those facet joints, we would need to do that under fluoroscopy with contrast confirmation and digital subtraction angiography. And then obviously you can inject lots of other ligaments and structures that might be involved. That's going to be very different than if you go get posterior injections with, quote, prolotherapy, or someone is not using fluoroscopy and they're just trying to do it under ultrasound, et cetera. So wide differences in what's considered a posterior injection at various clinics. Jessica, your expert opinion is C1, C2 fusion of waist, because most people have to go back and fuse their skull too. Yeah, I think you probably want to fuse as few levels as possible. So I don't think C1, C2 fusion alone is a waste. You're right in that you're probably going to eventually get, in most people, adjacent segment disease above at C0, C1. But I think that if you can avoid the C0, C1 fusion, let's say it's 50-50, that's better than not. So probably a good idea to fuse as little as possible. I think last time this was pronounced like Andrea. Opinion on getting an upright shoulder, elbow, and wrist MRI. Had a shoulder incident before developing CCI, but sensations typically the ulnar nerve with motion deteriorate upon getting CCI. Yeah, so I think if you're going to get your shoulder MRI done and your elbow and your wrist, those would be better with closed bore MRI, 1.5 Tesla, rather than a low field open, meaning that all of the opens are going to be, including all of the uprights, are going to be lower field magnets. So I think you'd want to go for a higher field magnet, meaning a closed MRI to get the shoulder, the elbow, and the wrist. Andrea, how useful are evoked potentials method diagnosis aspects of CCI at all? Usually not at all helpful. Very unlikely that evoked potentials are going to help. I'm trying to think what you could try to use them for. I guess you could try to use them to see if someone has cervical medullary syndrome, meaning pressure of the dens on the medulla or the brainstem. I think the problem there is it's going to be less reliable than looking at something like diffusion tensor imaging, specialized MRI through that area where you could see actual fiber disruption. Stephen, how significant can posterior PRP be for some of the sufferers of occipital neuralgia, if PRP can treat neuralgia at all? Yeah, Stephen, so it can be added, but again, realize that you have to do a very specialized hydrodissection of the occipital nerves with that. So that's what we would do at Centeno-Schultz, but the likelihood of you getting that just out there in the wild is small, meaning that that's a very specialized procedure that the doctor has to learn how to do in a very specific area that needs to be treated. Asthma, pain at the base of the skull can be caused by irritated nerves, rectus capitis, and joint capsules. How can the muscle and capsule be seen on imaging? We don't have a lot of data that the joint capsules participate at all in causing headache pain. So that's not accurate medically, even though you might have heard that from somebody. The rectus capitis posterior minor is the one I think you're thinking of, and that jacks into the myodural bridge, and that can cause headache. As far as the rectus capitis posterior minor, I have a whole YouTube on that one. Let's see if I can find it for you. Let me go and switch the share here. Let's see here. So if you go to my YouTube channel on the videos here, you'll be able to scroll down there, and this is one on the myodural bridge here. Talks about the myodural bridge. There's also one in here that talks about the rectus capitis posterior minor. So that's another one to look at as well. So those are different ones on my YouTube channel. If you guys don't subscribe to my YouTube channel, hop on there and subscribe. If you're on YouTube now, hit the like, share, comment, all that good stuff. Cheryl, if someone gets the PICL and posterior injections, would they need to come back within 4 to 6 weeks? More posterior PRP treatment with the bone marrow as well at the back. Thank you. Yeah, so normally we do not do additional posterior treatment in that 4 to 6 week range. I don't think there's any need to, based on how it is we're doing these treatments, meaning that I know there's lots of clinics that'll inject every 4 weeks, but they're not injecting the same doses of PRP we are. They're not able to put those PRP into specific areas. So they're basically relying on frequency of treatment to make up for injecting inferior stuff and injecting it less precisely. So you don't need another treatment at 4 to 6 weeks. Stephen, thoughts on what could be going on with a pounding heartbeat headache only in the back of the head? Yeah, so that could be occipital artery there. Occipital artery runs with the occipital nerve. So realize that could be possible there, that's what you're dealing with. Before I take the next question, again, I'm going to put in another plug for Reddit. Please join us here on Reddit. We've got 224 patients that have joined us so far. This is all things CCI, all things PICL. I jump on here 7 days a week and answer questions, patient questions, and it's a great place if you've got questions on PICL, because you can search anything up here on things that have been answered prior. Carol Yates has been advanced by Harry. Would headaches originating in the neck need to come from a neck injury, or could they also come from a neck abnormality you were born with? Usually a neck injury, while it's theoretically possible that you might have something you were born with, that's going to be much, much less likely. Jessica, so if you have alar ligament problems, since alar connects C2 to skull, how is instability only shown on C1, C2 lateral movement? Yeah, so there's two things that are being shown when you see C1, C2 lateral movement. Alar ligament controls rotation, and a proxy for that rotation is that lateral movement that we do, C1, C2 overhang on AP lateral bending DMX views. The accessory ligament can also control C1, C2. So we're really measuring the alar ligament and the accessory. Realize that the alar also sandwiches in, if you will, the atlas between the skull and C2. So that's another way that it's controlling motion at everything from C0, C1 to C1, C2. Jessica, so in your expert opinion, to pick 3 important components to hopefully one day free a person from CCI, I may ask what those would be. Yeah, number 1 is get a specific diagnosis on the specific type of CCI you have, i.e. which ligaments are involved. Number 2 is target those ligaments with injections. Number 3 is obviously the ligaments and other structures that are causing symptoms. As we've gone over today, lots of things can cause headaches. And then the third is get strong, meaning try to work on the core musculature to support the head on the neck. Asthma Al, what could be the reason for the sand rubbing noise around C01 when you turn your head? That could be a CCI type 1D. That's rotational instability at C0, C1. So that's something that could be something we want to take a look at. Video now working. Asthma, can you have pain at the base of the skull and a feeling of compression and stiffness, but without any ligaments of upper neck being damaged? Yeah, absolutely. That would be more craniocervical syndrome. And that could be the C0, C1 facet joint, the C1, C2 facet joint, the C2-3 facet joint, all three of those, suboccipital muscles, etc. Colleen, my son-in-law, suffers from unbearable headaches, and they now found a spinal leak. Any thoughts on interim relief or best long-term relief remedy or just surgery? Yeah, Colleen, a lot depends on, number one, is the spinal leak causing the headache? Realize that finding spinal leaks on imaging is very, very hard to do. And then number two would be whether or not it's in a place where you could treat it with PRP or a blood patch. If it isn't a place where you can treat it with PRP and a blood patch, then an injection makes sense first, because that can take care of a large chunk of spinal leaks. You're basically just injecting stuff into the area to both plug the leak but also heal the hole. Then obviously, if that doesn't work, surgery would be the way to go. Stephen, hoping to get relief with posterior PRP, Regenix Las Vegas. They only offer C1 through C7. I've been starting treatment Centeno-Schultz, 12-hour drive for me. Mahapa County, Arizona, is awake and effectively treat C01 with posterior PRP for my self-suspected occipital neurons and cranial with it. Yeah, so Stephen, that's certainly going to be good. I'm hoping that they're going to be injecting those facet joints. Normally it's C1, or it's the skull base through C7 for the posterior ligaments, and then for the facet joints themselves. The facet joints themselves are usually going to be the upper cervical facets. There's really no reason to inject all the neck facet joints. So I'm not quite sure what you're describing there, but I think that's going to be a step up, certainly from going to a clinic that is just going to do some blind ligament injections. KCN, or the facet maps incomplete, given that facets can lead to myofascial involvement with different referral pains. Yeah, KCN, I don't think that's accurate. I'm not quite sure where you got that one from. Facet joints don't usually lead to myofascial involvement. They're very specific referral patterns. Jessica, so pain and resistance in turning your head to the left. If you have a low-lying tonsil, can something be hitting that makes that pain happen? It can, Jessica, but be very careful, meaning at the end of the day, there's much, much more common things that can cause what you're describing than low-hanging cerebellar tonsils. So that would be at the very bottom of the list of things that could cause that. Higher up of the list would be things like C1, C2, craniocervical instability, a C1, C2 facet joint, a specific occipital nerve, one of the suboccipital muscles. So a long list of things well before low-hanging cerebellar tonsils. Reese Law 2, I'd actually hope you're well. This exact issue looks at neurology and trying to treat as much as you can without surgery. Yep, gotcha. Andrea, when you mentioned the SCM, are tingling sensations at the base of the SCM where it meets the clavicle a part of this? Yeah, they can be, because that can be the transverse cervical nerve or the supraclavicular nerve. But realize that is that area is innervated by the nerves that come out of the back of the SCM. Rishi, I have two plastic surgeons who only do occipital nerve decompression, but they know nothing of CCI instability. My major concern is to do surgery. It might expedite me in the fusion. Time that its muscles need to be removed or manipulated. Really. Yeah, Rishi, I think as we've talked about, you wouldn't want to do the surgery unless you knew specifically that it was the occipital nerve. So that's differential blocks there to try to figure out where the occipital nerves are getting compressed, or an MR neurogram. MR neurography can identify specific areas where the occipital nerves might be getting compressed. In addition to that, then you would do follow-up blocks. And let's say it's the greater occipital nerve at the rectus capitis posterior major. So you would do a plain block at the rectus capitis posterior major, see if that takes the headaches away, and then you would know to go after that spot. Cheryl, if a patient was international, had instability in the hip, would you use a stronger treatment to save them less travel over back to Colorado? Yeah, Cheryl, we frequently treat lots of different parts and pieces within the body. So at the end of the day, just realize that we're not only treating the craniocervical instability. Usually we're treating other things. So we would just treat the hip at the same time in all likelihood, unless you're a fragile leg patient and you won't tolerate two areas. And that's more rare, maybe 1 in 10 of our patients. Andrea, is deterioration of CCI inevitable if left untreated? That's generally what we see in most patients that have had it for a while. Yes, it tends to get worse, not better. Now, having said that, there are patients that can bend that curve by doing all types of conservative care. And there are some people where it just seems to get better over time. So, realize that, that's not everybody. Melissa, is there any correlation to pain in the V2 branch of the trigeminal nerve maxillary and the neck, or is it highly unlikely? Yeah, Melissa, I think what you're talking about is that there's some overlap between headaches that involve the trigeminal nerve and some of the other structures. There's even a ganglion involved in all of that, where there's some theories that there's some crosstalk between the two. So there could be correlation there. Realize this could more cause sinus headaches because V2 innervates the inside of the sinus. So a sinus headache without there being a sinus infection would probably be more related to the V2 branch of the trigeminal nerve. It's been advanced by Roberto. Do you have any doctors in Spain? No one to recommend in Spain for this kind of stuff, regrettably. Now, does muscle spasm go away on its own once instability is reduced, or is that something we need to work on via manual therapy? Usually muscle spasm goes away on its own once the instability is reduced. Andrea, thanks for the input on evoked potentials. If this kind of testing pointed to a delayed signal in the upper cervical area, what can this indicate? Yeah, usually it's not that specific, Andrea. So what I mean by that is that at the end of the day, it's not going to point to the upper cervical area, regrettably. More likely than not, what you're going to get is somewhere along this pathway from the brain to where we measured the evoked potential, there's an issue, but it's not going to be able to point to the specific upper cervical area at all with an evoked potential. It's one of the problems with evoked potential is they don't give you that kind of information. That's why I was saying a diffusion tensor image could give you that kind of information. It could focus on the function of the nerves right there where the dens seems to be compressing the medulla and upper spinal cord, and could literally pinpoint it to that spot. Stephen, had a Zoom call with you in mid-2024, had poor DMX image quality. You asked me to redo it, which I did during my Zoom call with you. You had mentioned I Chiari 0. After I redid second DMX, received an email from your assistant saying, plainly, I've got CCI type 2B. I feel like I need another Zoom with you. Or if you can please go over my case and elaborate more on Chiari 0, my type 2B. Yeah, so Stephen, the best thing to do, and what I offer everyone that does a Zoom call with me, is just to reach out via email, and I'll be certainly happy to take another look at your information, but it sounds pretty simple, right? I mean, at the end of the day, I think what you're talking about is you've got craniocervical instability and a Chiari 0. If you go to my YouTube channel and you go just search under Chiari, I have a number of videos that talk a lot about different things in Chiari. And basically the concept is simple, and that is that Chiari 0 is a normal variant. There's lots of people walking around with Chiari 0 that have no problems. They live their life with no issues, no problems. And then they get instability in the upper cervical spine, and it's like putting gasoline on a bonfire. So they get many more symptoms. So I think that's really the discussion I would have with you, is that it's a 1 + 1 = 3 situation. You're really not a candidate for posterior injections if you've got a type 2B, because that's very unlikely to help. So I think you're probably wasting some money there by trying to treat it with posterior injections, because in our experience, that only works about 1 in 5 times. You really need to get more of a PICL procedure. But I think you have my email, but if you don't, I'll put it down here in the comments. Let's see here. It should be going into the comments now, wherever you are, but just send me an email directly and I'll go back. Probably Monday would be a good time to ping me, Monday morning, because I'm in the office, and I can go back and pull up all your old imaging and take a look at it and advise you the best I can. But normally you don't need to do a second Zoom call. Just literally reach out to me via email. I probably answer 100 patient emails a week. I'm unique in that. Most doctors usually don't do that, or they have their staff do that. But I try to do it as much as I can myself. Cheryl, doctor, when I move my head to the left or right, I can feel a grind in my upper neck and I feel extremely dizzy. Yeah, so that sounds more like a C1, C2 facet injury that could be related to instability at C1, C2, or atlantoaxial instability. Now, could be other things as well. So I can't diagnose based on a sentence over the internet, but just realize that those are the kind of things that you would start to look for. So what are the next steps there in trying to make that diagnosis? Next steps would be obviously getting a neck MRI, see if there's anything going on there that's really big. If there's nothing on the neck MRI, then getting movement-based imaging, an upright MRI with flexion extension, for example, a digital motion X-ray, flexion extension X-rays, those sorts of things. Asthma, how is 1D instability detected? We can see it in MRI or CBD flexion extension. CBCT with rotation could possibly find it. We'd be looking for more than 8 degrees of C0, C1 rotation, right or left. You could also theoretically do it with a rotational MRI as well. I think we've already answered this one. Yeah, so I think you got my email. And Andrea, but would you say that an upright MRI of the shoulder elbow? No, I wouldn't. There's no advantage to do an upright MRI of your shoulder, elbow, or wrist at all. You'd be far better doing a closed bore MRI of those structures. There's just no advantage to gravity there. Cheryl, that's great. Can you treat multiple areas at the same time? So with hip instability, you only need one treatment. Yeah, so I would need to look, Cheryl, at the actual issue, need to perform hands-on physical exam, hip MRIs, etc., and then I could give you some sense of that. Zach, I have FAI with a pincer. I want to get damaged hip labrum repaired with stem cells in the Grand Cayman Clinic. Should I have the impingement removed for the stem cell procedure? No, because FAI with pincer is normal. What I mean by that is that a pincer type impingement forms in order to protect the joint. So it's protective of the joint. So removing it would hurt the joint. So you don't want to remove it, even though the surgeons have this thing where they love to remove anything FAI related. That's not science-based, regrettably, in this particular situation. Rishi, have you met any CCI patients told you occiput surgery and made them feel more unstable? Lots and lots, Rishi, which is why I think we've had that conversation. We've seen lots and lots of decompression patients who have had CCI through the years. That's my email address that goes to my desk. So I think I was talking to Stephen about that. Centeno office at Centeno-Schultz is not a general email. It's the specific email that goes to my desk only. Zach, won't the impingement re-injure the labrum after the repair? No, Zach, there isn't any impingement. That's a fiction, meaning at the end of the day, the type of, quote, impingement you're describing really is an impingement. It's a response of the hip joint to try to protect the joint. So there's no rationale to remove it. So it's not an impingement, even though the surgeons call it an impingement. It is merely a protective bone spur that is formed to try to protect your joint. So removing that bone spur is a dumb idea, not at all supported by the science. Now, if you had a severely small hip joint for the ball, so if the socket was too small or hip dysplasia, then you could make an argument that reconstructing the hip may be worth it with surgery. But what you're describing isn't impingement, even though it's called one. It's a protective bone spur, and you don't want to remove a protective bone spur. Otherwise, you're going to hurt the patient. So we don't want to do that to patients. And let me go here and go back over here. Any other questions I can answer today? Put them up. In the meantime, I'm going to switch the share for a second here. So again, please like, comment, share, subscribe. If you're watching this, for every one of you, there's 10 to 100 patients out there who probably need to hear this, but they can't find it. So please go ahead and try to like, comment, share, subscribe so more patients can find this information. And then again, as I said, consider joining our PICL or the Reddit sub on PICL or patient-only Q&A here on Facebook. I got two more questions here. Zach, if the bone spur damaged labrum initially, why would it not re-damage labrum after repair? It did not damage the labrum at all, Zach. That's the issue I'm trying to explain to you. That's a fiction. So it is a fiction that the bone spur damaged the labrum. In fact, the newer research on this type of spur shows that the spur is there to protect the joint. It did not damage the labrum. In fact, it formed to protect the labrum and the joint. So taking it out makes no common sense. Stephen, anything in the future for insurance coverage on PICL? We're supposed to be, would help me, but deep down feels like I need a PICL. Sounds like you need a PICL. We have insurance coverage through 3,500 employers for the PICL on a couple different plans. Samaritan Ministries is one. In fact, I've got two patients coming in here soon that are getting covered by Samaritan Ministries. That's a church-like health plan. There's 3,500 U.S. companies that cover this. Everyone from John Deere, big tractor company, to Under Armour. Obviously, everyone knows Under Armour. Lots of large companies cover this, and we are taking it down one company at a time. There's not a week that goes by that our team isn't out there trying to get more companies to cover this procedure and things like this. Lindsay, sorry I'm late to watching. Does hydrodissection make the muscles more unstable? It does not, Lindsay. That's the good news about hydrodissection, is that it's about the most gentle thing you can do to try to open up an area for a nerve, whereas surgical decompression can damage the muscles. Cheryl, how long after PICL should the patient start to feel improvement or any treatment? Thank you, doctor. Well, specific for PICL, we're looking at the 2 to 4 month time frame, usually on average about 3 months. For other types of treatments, different time frames. Casein, do you use any other injectate other than lysate for hydrodissection? We use both a third generation platelet lysate as well as sometimes high dose platelet rich plasma that's leukocyte poor. The more leukocyte poor, the better, because any leukocytes or white blood cells in the mix is going to cause inflammation. Inflammation around nerves equals a bad day for everybody. So those are the two things we tend to use. And then obviously, if we're down in Grand Cayman, we can also use platelet lysate with mesenchymal stem cells added, which can be very effective as well. Thank you, Dr. C. Amelia Monday, very about my case. Yeah, I'll look at everything again, Stephen. Again, just realize that, you know, for anyone I've done a telemedicine on who's on here or who's watching this after the fact, just realize that I'm always happy to answer email questions, just random ones for those patients. That's a commitment I try to make to them. Now, please don't abuse it. I mean, I don't want 100 emails after doing a single telemedicine, but if you've got a couple of questions after I've done a telemedicine, just feel free to email me, and I'll be happy to try to answer it as best I can. You can also go on to the Reddit sub here, PICL, and you can get a question answered directly by me here. And then if you're interested in getting patient questions answered, the craniocervical instability PICL procedure is a great place to get other patients who are very experienced with this stuff to answer your questions. Happy to help, Zach. Yeah, at the end of the day, the goal here is to try to teach patients, and it's awful to me that surgeons are still operating on pincer deformities because they shouldn't be. The only type of hip deformity that's been shown to be very effective is actually a hip dysplasia where there's a short socket. But when it comes to pincer deformity, it's not an impingement. It's merely a bone spur that formed to protect the hip, and you don't want to remove it. Andrea, great. I'm hoping I'm getting your name correct. Maybe I am, maybe I'm not. I thought I remember it was pronounced more like Andrea. Okay, guys. Well, I think we're running out of questions. We're coming up to the hour. I want to thank you for all the great questions. Again, I sincerely believe that patients learn through asking questions. This will be on Facebook. It'll be on YouTube under Lives. And let's see here. Cassian, do you get lysate with ultrasonic treatment, or are there other treatments other than the freeze thaw? I don't know what you mean by that, meaning that we use ultrasound imaging to perform nerve hydrodissections. And then freeze thaw, I would not recommend at all. That's cryo treatment of a nerve. So cryo treatment of a nerve is to destroy the nerve. We don't want to destroy nerves if we don't have to. That's why we use things like platelet lysate hydrodissection, so that we can help the nerve and not destroy it. Lindsay, looking forward to starting PICL tomorrow on St. Patrick's Day. Yay. I don't know if I've got anything green, Lindsay. I certainly don't have green scrubs, so I don't know if I'll be wearing something green or not, but thank you for your confidence. Okay, guys. I think you mean, yes, we use ultrasound guidance, meaning ultrasound is used to guide the needle to the specific spot it needs to be. That's very different than ultrasound treatment in physical therapy, where ultrasound treatment is to heat up tissues. That's a different kind of ultrasound that we use to actually see the nerve. So that's why it's used. Okay, guys, thanks so much for watching. Have a great week. I'll be back next week with another interesting topic, and we'll go from there. Thank you.